Start the instruction course, I will invite Dr. SOVEETA Rath. She is a pediatric ophthalmologist. At a young age, she has published more than 12 papers in pediatric ophthalmology. She did her post-graduation and fellowship from LV Prasad Eye Institute. So she will be speaking on amblyopia management. Dr. SOVEETA, please.
Good morning, everyone. I would like to thank Dr. Rishimai and Team AIOS for giving me this opportunity. So, unexplained vision loss in children explained. And we begin with amblyopia. So as we all know, when we ask our residents and fellows, then amblyopia is something poorer than 20/40 on Snellen's chart. But actually, it's a unilateral or bilateral decrease of visual acuity caused by deprivation of pattern vision or abnormal binocular interaction for which no cause can be detected, but there are some therapeutic measures which would reverse it. Now, what are these measures? This has been studied by PDIG, which is Pediatric Eye Disease Investigator Group, answering a multiple questions which says us whether glasses are effective alone or not, if patching works, how many daily hours of patching, and if patching is stopped, what happens, does atropine work as well as patching, how often it is to be done, and what more. So a number of studies by ATS has been performed, and this brings us to some of our preferred practice patterns which we are following, all of us are following today. So yes, glasses does alone treat amblyopia, as published by ATS 5 says that initially we must treat with spectacles. The refractive correction has to be done, followed by the period of adaptation, maybe up to 2 months, and then we can add on patching if the vision does not improve. So treat with spectacles alone until improvement starts. If patching is needed, the visual acuity is likely to be better when patching is started later compared to starting it at the same time. Papers have seen that the optimal timing is at 30 weeks when the maximum correction has been achieved, and then it plateaus. But we all know the gold standard after the refractive correction is occlusion therapy. Multiple type of patches are available, and it is from ATS 2A, 2B, 2C that we see that based on the degree of amblyopia, the amount of patching has been recommended. It is the most effective therapy, useful even in adults, and has a role in delayed presentation also. The success of patching ranges from 19 to 93%. Now we all know this such a wide range is because of multiple issues, including compliance. 120 hours of conventional patching improves visual acuity by 0.1 logmar. So the issues with patching therapy is compliance, additional near activities when we recommend, the dose response curve is always not predictable, and it has been seen that there is recurrence on abrupt cessation. Also, there is lack of parental understanding. Parents do not know the result, and hence they are not sure to accept it as we say them first time. Also, the child, even if the child is small, has a social distress. So is there any alternative to patching? They begin with penalization, either atropine or optical, as recommended by ATS1, where 1% atropine weakened dose into the good eye, or a positive defocus over plus glass on the non-amblyopic eye. This was more useful in cases who had compliance issues, or there was occlusion failure, and as a maintenance treatment. There was substantial improvement in the amblyopic eye with both treatments. Hence, also they found that there was more rapid improvement, but the improvement was faster in the patching group. However, it remains a secondary option today also in our clinical practice, but we need to closely monitor the visual acuity of the non-amblyopic eye. Papers have reported 26% systemic side effects with atropine, and that needs to be observed. Next comes the pharmacological agents, which are practiced by some, but are not a very common preferred practice. Oral levodopa, carbidopa, which acts beyond the period of plasticity by causing visual cortical activation. By the Daya et al., they had given 0.5 mg with 1.25 mg of levodopa carbidopa per kilogram 3 times along with a protein-rich diet, and they found 2 lines improvement in visual acuity, more in the levodopa group, more in children who were less than 8 years of age. And they recommended this, that it can be given in children less than 8 years of age where compliance is a major issue. The other agent is citicoline, which increases the levels of neurotransmitters. It also has a neuroprotective effect. But in this, again, we have studies from Indian eyes. So in this study also, by Pawar et al., they found that the initial 4 months was a plateau phase where patching or not patching, they had the similar effect. And then citicoline was added, where the dose was 250 mg OD for patients below 5 years and 500 mg for patients above 5 years. And it was seen that the result was same in younger patients as well as in older patients. In phase 2, the mean proportional improvement in group 1 was then significantly more than in group 2. Then comes a liquid crystal glass, which has not become so acceptable. It is an electronic controlled occlusion, so something which is mechanized. The occlusion is now by intermittent flickering shutter mechanism, where on is the occlusion and off is the light transmission, which alternates at 30 seconds intervals. It was cosmetically acceptable. The preliminary studies showed good results in moderate amblyopia. However, there are no proven studies on long-term outcomes. We also have perceptual exercises as it began as an active therapy, which was based on the principle that whenever we expose something to a pattern stimulus, it is accepted more commonly, and this will also have a better influence following a practice or experience. So a consistent practice is needed. So there they used pattern stimulus in the form of sine wave gratings that would stimulate the cortical neurons and improve the binocular interaction rather than the uniocular vision with the previous modalities has been doing. However, it needs a home-based training system. There was lack of sustained effects on stopping the treatment, and the long-term follow-up is not available. Thus, the limitations of present treatment are poor compliance to patching, recurrence, and poor effects in older children. Patching also does not improve, as I said before, fusion, stereopsis, fine motor skills, hand-eye coordination, all of this which would have an impact on the quality of lifestyle. This brings us to the evolution of new modalities after it has been studied that it is the dichoptic exercises which would help to improve the binocularity in children as well as adults. So they began with video games, which on using enhances visual functions by causing selective attention. There were 3 approaches, either to improve suppression, to improve crowding, and increase stereopsis. The studies have showed that it induces functional plasticity in adults. However, PDIC said that it was not better than patching. This is one of the examples which taught us which was brought as interactive binocular treatment for amblyopia. There they present 2 separate images to each eye on a dynamic visual scene, preferentially stimulating the amblyopic eye. And this was mostly acceptable at that time because it was an interactive game improving patient compliance. But PDIC, when compared patch and iPad, so iPatch and iPad, it was seen that there was improvement of 1.4 line, and improvement persisted till 6 months, and they had excluded prior history of children who had patching history. However, iPad studies did not exclude children who had history of patching, and it plateaued after 4 weeks, though the result was comparable. Then the dichoptics, which is a true dichoptics which affects a binocular stimulation, is by presenting 2 differential contrast to both the eyes. An alignment procedure assures that the stimuli will overlap. The contrast adjustment is there to balance the perception of 2 images, and thereby a subject with nascent binocular abilities should be able to do the task. These are some of the examples where binocular or true dichoptics was used as Tetris and Digrush, and it was concluded again that though they affect the binocularity, it was seen that improvement was more in adults, but there was a bias by previous history of patching. The trend again favored patching, and here also there were dropouts with poor compliance, no specific dose response relation. Still, since it is a iPad game or a video game, and it can be given as a home-based exercises where compliance is an issue, it is preferable. These are some of the software-based active treatments which are being practiced nowadays, which uses the principles of operant conditioning and behavior modification, where it is like a reward to the child as they perform more, their level increases. So patients begin therapy with targets that are easily seen and then becomes progressively smaller as the therapy progresses. This is another one, Binocs, which many of them are using. It can be used in some cases which have small angle strabismus also. And this is one of our collaborations where SCH and IIT Delhi has brought about a window to vision therapy, which will also be helpful to give perceptual exercises not only in amblyopia but also in children who have neurological associations. and thereby causing giving a better result with prolonged plasticity of in cases with have prolonged plasticity of binocular neurons. So the indications basically for all this are the residual amblyopia, adult amblyopia, faster effects, better compliance with effect on binocularity, improving fusion and stereopsis, and effect on visuomotor skills, thereby improving eye-hand coordination. This is the newest concept which is being used again is Revital Vision. They have claimed that it is an FDA approved amblyopia treatment in adults greater than 9 years, again affecting the perceptual learning and causes a visual acuity improvement by 2.5 lines. They say that eye deviation up to 8 prism diopters, and this is again useful because there is motivation and willing to comply with the training tasks, and the vision is stable even after stopping the treatment. Orthoptic is a novel perspective which has been given by Dr. Gopal, and it focuses on visual attention, where it causes a top-down impulses from the parietal cortex till the occipital cortex, and it also is useful to improve stereopsis, visual acuity, hand-eye coordination, motor alignment. Irrespective of all ages, it is useful, and people are using it nowadays. So what we need to offer to our children are a cost-effective therapy for the parents, which will be compatible and compliant for all the children, which would give faster results so that the compliance is still reinforced, and our treatment should cater to a wider age group. Thank you.
Thank you, Dr. SOVEETA. Just one question. What is your experience with patching versus dichoptic exercises for amblyopia?
Sir, always patching is the first modality. So but some of them who like 6-12 beyond that, they don't improve and all, then and they are non-compliant, then dichoptic exercises have shown a good result. But it also will, we will also want that they should have good compliance, even for the dichoptic therapy. It has good results. Basically if they present late and if they have a poor vision to begin with, then we cannot work. Either it is patching or it is dichoptic. But with combined effect, you initiate patching and then you give dichoptic, at least 1 line or 2 lines visual acuity is improving.
Okay, thank you. There are a lot of questions regarding amblyopia.
So, Dr. SOVEETA, one more thing I wanted to ask, to ensure compliance, are you doing anything specific? Because I find that almost 40% of my patients who are put on dichoptic therapy, I don't even have them back on follow-up after 6 months, after completing the entire
No, ma'am,
series.
we are not doing specific protocol, but yes, we can give them some tables or charts or a calendar. Home calendar can be advised, where we can ask them to bring that calendar on our every visit so that we know whether they are compliant or not.